Thank you for being here today. My name is Jim Bueller, and I am here on behalf of the Urban Health Collaborative, which is sponsoring this session of the Population Health Spotlight. And I'm very happy today to be able to introduce Dr. Stephen Woolf. Dr. Woolf is the founding director and now director emeritus of the Center on Society and Health at the Medical College of Virginia Commonwealth University. The center works to connect the dots between social factors and health and represents a presence for public health in Virginia, a state that I learned to my surprise today has no school of public health. Dr. Woolf is a professor of family medicine and population health and holds the C. Kenneth and Diane Wright Distinguished Chair in Population Health and Health Equity at VCU. And I'm going to depart just a little bit from the prepared bio that you all have that accompanied the announcement and touch on just a few points. Dr. Woolf received his MD degree from Emory University, where as a medical student, he thought he would take an elective course in epidemiology, and based on that experience, came to the conclusion that he had no use for the science of epidemiology as a future physician, and he performed so poorly in the course that his instructor approached him and offered to provide some remedial assistance, which he tactfully declined. However, over time, his position evolved. He developed an interest in public health. He completed an MPH degree at Johns Hopkins and later completed his clinical training, residency training in family medicine. His interest in the social determinants of health was spurred by the opportunity to work in the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services very early in his career. And that launched him on a career path that has integrated the disciplines of epidemiology, health services research, policy, advocacy, and primary care. His successes in connecting those dots between social factors and health has led to his providing testimony before the U.S. Congress, service as a member of the U.S. Preventive Services Task Force, and service as the chair of the National Research Council Institute of Medicine's a task force or committee that compared the health of Americans with that of their peers in 16 other high-interest countries. I can think of nobody who is better qualified to address the topic of his lecture today, Understanding the Decline in U.S. Health. Dr. Woolf, welcome, and we look forward to your presentation.
While I hook up my mic, the point of that story for the students is you can recover from a D in Epi. I'm not sure how great a job I did, but I did recover from it. But actually, the moral of the story, as I shared with some of the students during lunch, is don't put up blinders, because some of the things you don't think you're interested in may turn out to be very relevant. Well, I'm very happy to be here. It's a real treat. I arrived yesterday late afternoon, had dinner with some faculty, and then spent the bulk of today until now meeting with faculty and students. And it's been a treat for me because I've never been to Drexel before. I've been to Philly many times, but never set foot on the campus. And I'm just really impressed. You all have a great institution here and a great school. So I'm here to talk to you about the cheerful subject of the decline in U.S. health. The situation is actually rather dire, but it's the kind of thing that sort of makes the work that we do in public health very important and timely right now. I'm going to probably go through the slides quickly because I don't want to spend so much time on slides that we don't have a time for questions and discussion. So forgive me if I go too fast. So let me first establish the premise in the title about the decline in U.S. health. There's been a fair amount of media coverage about the recent news that life expectancy has decreased for 3 years in a row. You know the science well enough to know that for the past century at least, life expectancy has been increasing in industrialized countries, the U.S. included. So it's a big deal when life expectancy starts decreasing. If it happens for 1 year due to a particular flu epidemic or what have you, that's one thing. But when it happens year after year, it gets a bit more worrying. The media coverage makes it sound like it just happened, but actually what we're really seeing is a long-term trend. So this graph is showing U.S. life expectancy plotted against the life expectancy for an average of OECD countries starting in 1995. And you can see actually it was around 1998 that the U.S. started to fall below the OECD average. But if you go back even further, you get a better sense of the long-term perspective. You can see that once upon a time, when I was young, the U.S. had higher life expectancy than the OECD average. And something clearly started going awry a while back. Probably around the 1980s is when the slope really started to change. So although the life expectancy decrease in the past 3 years is alarming and very disturbing, the source of the problem is old. And so we have to understand the decline in U.S. health from that long-term historical perspective. All this despite the fact that we spend way more than any other country on health care. So often the politicians will say that we spend more and we don't have better outcomes to show for it, but it's really a far worse story. We spend way more and we're dying early despite all that spending, which is a good example of why health is about more than health care. That's the reason why all that spending on health care isn't solving this problem. So Jim mentioned the committee that I had a chance to work on, and your dean, Anna, was a member of that committee as well. This is a committee co-sponsored by the National Research Council and Institute of Medicine about 7 years ago, which was commissioned to look at the question of why the U.S. has poor health in other countries. But the first job of our committee was to document the scope of the problem. You've seen the life expectancy numbers, but to look a little more deeply into health statistics for the U.S. compared to other countries and see just how bad the problem was, and then go on to think about what was responsible for it. So these were the countries that we were comparing across our study. And what we found was not only that life expectancy was worse, but that mortality rates were also higher in the U.S. for many conditions. And for those of you in the back of the room, certainly if you have my eyesight, you can't read this, but you won't really need to. All you need to know is that this is a list of conditions that have higher death rates in the U.S. than in other countries. This is the list where the U.S. death rates are equal or lower. So you can see there's a lot more on this list. But the other thing that's really interesting about this list is how diverse these conditions are. You'll see on this list pediatric problems. You'll see diverse chronic diseases for adults. You'll see injuries. The point being that it's very difficult, if you're putting yourself in the position of being a member of our committee, to think of a magic bullet or single cause that would explain such a diverse set of disadvantages. We looked a little bit at trying to zero in on which age group seemed to be the culprit for this disadvantage. Is it infant mortality that's the problem? Is it something in middle age? Is it the health of older adults? And we got this result, which was pretty alarming, which is that for every age group, from birth all the way until you're in your 70s, the U.S. was at a disadvantage. But if you can make it to age 75, you're better off in the U.S., but otherwise, not so much. And we have a lot of graphs. I'm not going to spend too much time on this, but I'll just share this particularly stunning one showing the probability of surviving to age 50. So to understand this chart, first of all, it's starting off in 1980, so to give you a sense of the perspective. The gray dots represent the comparison countries. The red dots is the U.S. And as you can see, for males, that period started off with the U.S. somewhere within the range, and then it fell down to the bottom. But look at females. They're completely coming off the charts. So effectively, what this is saying is that the probability of a woman surviving to age 50 is lowest if it's an American woman. And a pattern that we actually saw quite a bit in our report, and in other research as well, is a female disadvantage, where American women have a particular health disadvantage relative to women in other countries. So in modern times, when we think about, well, what's responsible for this decline in U.S. health, the reflex is to think about the opioid epidemic. And in fact, that is a pretty alarming public health crisis that we're having now. This graph is showing mortality rates from accidental drug overdoses starting in the 1990s, and it's stratified by race ethnicity. And you can see that across racial and ethnic groups, we've seen an increase in mortality rates from this cause. And some are inclined to attribute the decline in U.S. health to this problem, either solely or as a very large factor. And it probably is. But the interesting thing when I look back at our report, which was published 7 years ago, is that we identified 9 different domains where the U.S. was underperforming compared to other countries. Drug-related mortality is in bold here, wasn't in the report, but I highlighted it for you to say it was on our list. But certainly the problem is broader. And in fact, if you look more specifically at cause-specific mortality rates that I'm going to get to in a few minutes, there are many other examples of the U.S. having increases in mortality rates, especially for people aged 25 to 64, which for shorthand I'll call midlife, but those of you in your 20s are not in midlife. It's important for me that you not think of yourselves as being in midlife. So when our committee set about thinking about, well, what's the reason for the U.S. health disadvantage, we developed this diagram to start organizing our thinking. And it's very simplified socioecological model that you've seen probably much more complex versions of, but helped us think about, well, what if we think of health outcomes over here on the right as our dependent variable that we're focusing on, and its poor performance in the U.S. What is it about these different domains, which we know are important in shaping our health, that's different in the U.S. from those other countries? So we know our health is shaped by our behaviors, such as smoking and physical activity. It's affected by our healthcare system, but we also know the important role of social and economic factors and environmental factors, both physical and social. And then at the macro level, the role of public policies and spending decisions in shaping all of those domains. And I won't get into the details. We can talk during the Q&A if you're interested about what we found when we looked at each of these domains. But it did help organize our thinking about where the U.S. differs from those other countries. And that diagram is one, it's the legacy of many years of different diagrams that have been published trying to help explain this multi-level relationship between the factors that shape health. Among those, though, and this is something where your dean has been a leading scholar, is emphasizing the role not only of the socioeconomic characteristics that individuals and households hold that have influenced their health, such as their education or their economic status, but the role of our environment, the places in which we live, our neighborhoods, our communities, the state that we're in, and so forth, and their important role in shaping health. Whether you're in an urban setting like on the left or a rural setting like on the right, we know that that's a major factor in shaping our health. And so it therefore doesn't come as a surprise, shifting from this international comparison that we're talking about to a more domestic look, that we see very marked differences in our health across the country at the state level. And what you see here is a typical pattern. This is showing life expectancy, and you see the lower life expectancy in the Deep South. You can map any number of chronic diseases, strokes, for example, and see the same kind of distribution. It does look different for different causes of death. For suicides, for example, it's more in the mountain states. But clearly, health varies at the state level. But then when you zoom in on any particular state, it varies even more at the smaller geographic units. This is showing life expectancy by census tract for California. And then as you zoom in further, and I know I've seen in the past few hours maps like this for Philadelphia, where you can see the dramatic differences in life expectancy across cities. Most of our major cities in the U.S. have these very large differences in life expectancy. One of the things we've tried to work on a lot at our center that Jim was talking about is trying to communicate this to the public. So people who are in academic settings like yourselves know this already and are used to looking at ArcGIS maps and so forth. But conveying this to the public or to the media requires a little bit of tweaking to make it a little more engaging and to sort of convey the message. So one of the things we've worked on here, this happens to be the map we developed for Philadelphia, is to take that kind of data that you have in an ArcGIS map and put it in a format that sort of conveys this message about the large gaps in health that exist across neighborhoods. This is showing a 20-year difference in life expectancy in Philadelphia. We've done this for multiple cities around the country. These are examples of the different locations on our website where you can see different maps. We just finished doing one for Washington, D.C., so 27-year difference in life expectancy. And when reporters ask us, why is this? Why is it that you have these big differences in health across small neighborhoods? This is the laundry list of things we go through. And if you scan the list, you'll see, the issues that you all are working on and studying about. Education and income is probably the most important of them all. But a lot of environmental factors in our neighborhoods, the built environment, food security, environmental injustice in terms of exposures to adverse events. Access to health care is on the list, but obviously it's of a piece of a larger set of issues that shape our health. So, as I mentioned, this exists in many cities across the country. This is the map we developed where our institution is in Richmond, where we documented, whatever that is, a 17-year difference in life expectancy. But I want to pick on Richmond as an example. I think I could do this for Philadelphia, but I'm choosing to do it for Richmond so that it can be a different city that I talk about. But I think you'll see parallels here in Philadelphia. Frankly, I think that you'll see parallels in most of our cities across the country where the same story can be told. Although it's a little bit special in Richmond, if you think about it. Richmond was a city that has a very tarnished history in terms of its role in the American slave trade. This is where the slave ships arrived. It was the capital of the Confederacy. So this is a place that has a long history around issues of inequity and racism. And there we have this large gap in life expectancy. When we produced our map for Richmond, the local newspaper produced this graphic to try to help the readers understand that these gaps in life expectancy correspond to large differences in health outcomes in other countries, to put it in perspective. So the neighborhood that had the lowest life expectancy on our map, Gilpin Court, is a public housing development. So they're showing the life expectancy for that particular neighborhood. So I was telling one of your faculty earlier that I've, at this stage of my career, become much more interested in history. I studied it as a student, obviously, but I don't think I appreciate it as much as I do now. I've spent so much of my career looking at these cross-sectional comparisons between, different groups and which demographic or other factors predict differences in health outcomes without taking that longitudinal perspective to think about how we got to this place. These neighborhoods that we're studying didn't come about by accident. They're not random events that they turned out this way. So Martin Luther King said this, modestly saying, "We are not makers of history," not knowing that he definitely would be a maker of history. But I think history is important context. So again, I'm going to pick on Richmond, but I think there's a similar ward that functioned the same way here in Philadelphia. This is a ward that existed in Richmond in the 19th century called Jackson Ward. It was a large, vibrant African-American community. This is a picture of the Hippodrome Theater where Duke Ellington and Ella Fitzgerald used to perform. There was what we in academia would call social capital, but it was a vibrant, culturally rich, and active community. There was discrimination in housing and access to property before redlining, but obviously redlining was an important force in cities across the United States. This happens to be the redlining map for Richmond. And if you concentrate your eyes on the east end of Richmond, that's what this area is called, it was an area that was heavily redlined, and then became an area for concentrated development of public housing units. There are 4 large public housing units. It requires a helicopter to get an aerial view of this one housing complex. There's 4 of them in a 1-mile radius. And a federal penitentiary was also placed out there in an area that used to be part of this socially vibrant East End. Then came the interstate highway system. And I-95, if you travel south and go through Virginia and through Richmond, you're driving right down this highway, was put right through the middle of Jackson Ward. So it bisected the neighborhood. And the same story is told in cities around the United States, that it was that section of town that was chosen by Turnpike authorities and other groups as the area where the housing would be raised to build the construction. And as you can do in many other cities, I'm sure it's done here in Philadelphia as well, you can put the redlining map up alongside current statistics and see an alarming parallel. This happens to be poverty rates that are being shown. These are those 4 public housing units I told you about. You can see that these are basically showing up in the same neighborhood. Life expectancy, same story. I mean, raise your hand if this has been done here in Philadelphia. Have you seen work like this here? If not, it should be done. And so this happens to be the redlining map for Baltimore. And again, the same kind of story, the map on the right showing areas that have had persistent poverty over the years. And one of those areas happens to be the neighborhood where Freddie Gray was arrested. This is the Time magazine cover from the protests that erupted after his arrest. But it's really only through that history that we have a sense of why there is so much rage over the way communities of color have been treated over the years. That helps to understand not only the multi-generational effects of exposure to discrimination and how they help explain the health inequities and other gaps in social opportunity that exist nowadays, but also the frustration and anger and pain that came with it. Then a few years ago, this started to appear in the news. This is New York Times coverage of a study by Case and Deaton at Princeton reporting an increase in mortality rates in white people. Middle-aged whites, the study said, were dying at increasing rates. And I don't know how many of you have been following this trend, but if you followed it in the media, what you heard very often was the portrayal of this as a phenomenon that's concentrated among whites who are middle-aged and living in rural areas. So the stereotypical news story would feature a middle-aged white person in a family in rural Ohio or something along those lines. And actually, in the study itself and in interviews, when people ask, well, what about people of color? Is this happening in people of color? The answer was no. This is something that we're only seeing in the white population. That set off a whole bunch of speculation about, well, why is that? Why would it be happening only in whites and not in other groups? Well, we can talk more about that, but this notion of deaths of despair was popularized, that among working class whites in particular, there was this sense that something was happening that was causing them to die at higher rates. And this phrase came about because the data were showing an increase in death rates from 3 things in particular. Drug overdoses was the major one, but also alcohol-related deaths and suicides. So the combination of all 3, drugs, alcohol, suicides, led to this sense that something was happening that was causing this greater despair in this population and leading to this increase in mortality rates. But it turns out that the premise that it was only happening in whites was misguided, and partly not the fault of the original investigators, because the changes in all-cause mortality rates started happening a bit later in the black and Hispanic populations than it did in the white population. So this is a graph from a BMJ paper that we published last year. It's probably very hard for you to read here, but this is showing the white mortality rate, and this is focusing on this midlife age group from 25 to 64. And what you can see is this 8.7% increase in their mortality rate starting around 2010 or so. And you can see that during that same period, there seemed to be this very dramatic good news in the Black and Hispanic population, where there were significant decreases in all-cause mortality that was actually helping to close the black-white mortality gap. But then, a bit later than among whites, the rates started going up. And this actually happened in some cases after the period of time that Case and Deaton were, their original study, I think, looked at data through 2013, so they missed this increase that was starting to occur in communities of color. Interestingly, the Native American population, all along, was experiencing a dramatic increase in these mortality rates. And the increase, both in absolute and relative terms, was way higher than the white mortality rate. And if you look closely, just a reminder of what we already know, even with this increase in the white population, look at the actual absolute mortality rate compared to the black mortality rate. The white population was nowhere near, even with this increase, nowhere near the very high mortality rates in the black population. So there's an interesting discussion that we could have about media coverage and bias in terms of how this was covered. There was nothing said really much about Native Americans, and still not enough attention given to the fact that this trend is occurring across these groups. This here is unpublished data for a paper that we're working on right now, where we've been sort of systematically looking at this trend of increasing death rates in this age group of 25 to 64. And in this case, just trying to quantify where, in terms of absolute numbers, where most of these deaths are happening. So the darker shaded states are ones that have a larger absolute number of excess deaths. This is just during the period of 2010 to 2017. And what's interesting about it is how concentrated it is, in the Ohio Valley area and Appalachia. So in effect, we're talking about the Rust Belt, industrial Midwest, including Pennsylvania, by the way, but also Appalachian states. By our calculations, half of the excess deaths in the United States that occurred because of this trend occurred in the 13 Appalachian states. And 1/3 of all the deaths occurred in 4 states: West Virginia, Indiana, Kentucky, and I'm forgetting what the 4th state was, but they're all there clustered together. Those accounted for 1 out of 3 excess deaths. So this is something that's not homogeneously distributed across the country. States like California and Hawaii really have had very little impact from this. And the most populous states, New York, Texas, and California, have seen relatively small trends in this regard. Again, the major factors that seem to be driving this trend are what some people have called deaths of despair or stress-related conditions. And we did a study where we tried to zoom in a little bit on each of these states that have been impacted to try to figure out where this is happening. And this is examples from the different states that we looked at. And the important takeaway here is that the trends seem to be worst in parts of the states that had experienced long periods of economic challenges, long periods of stable or stagnant wages, high unemployment rates, high poverty rates, rural areas that have suffered with the economy. Whether this is the reason for the trend is still something that further research needs to validate, but it's an interesting pattern. So for example, in California, it was the Central Valley and the northern rural timber counties, where the timber industry has been struggling in California. In Missouri, it was the Ozarks and the Boot Hill region that seemed to have the largest effects. In Virginia, where I'm from, it was the southwestern coal fields, where the collapse of the coal industry has left a lot of coal miners unemployed, and so forth. We did this project in collaboration with our colleagues at the University of Pittsburgh, and they were kind enough to share this slide from a follow-up study they did where they zoomed in a little bit on the Pennsylvania story. And again, you can see, although Philadelphia obviously has had its own increase, this pattern in the southwestern part of the state, which probably won't surprise you, but it's in keeping with the other findings that we're talking about, that this is a phenomenon that seems to be concentrated in this region. Again, from our colleagues in Pittsburgh, plotting by county in the southwestern part of the state, this increase for, in this example, accidental drug poisoning, and similar slides for suicides and other causes of death. But It's really important to think of this in the context of the larger Appalachian region, because this is obviously picking up the Pennsylvania portion of that. But this is an area of the country that has struggled economically for a long period of time. For an upcoming paper, we presented the mortality trends for the 13 Appalachian states, and all across them you can see important increases. Here's Pennsylvania's curve right here, where mortality rates have increased. And here again are data that are showing the actual results for each state. So just for Pennsylvania in particular, to single in on that, a 660% increase in drug overdose deaths and so forth. You can go down the list. I want to draw your attention to these other columns, because with all the talk about deaths of despair and the opioid epidemic, there's been a focus on drug overdoses and alcoholism and suicides. But if you look more closely at the data, what you find is an increase in mortality rates for a wide variety of organ diseases: digestive, respiratory, cardiovascular, maternal mortality rates, and so forth, all increasing in this same age group. So again, you can clearly justifiably worry about the opioid epidemic and blame a lot of this on that, but you can only go so far with that argument. It gets to become a bit difficult to blame increases in so many organ diseases to this one cause, and this speaks to the likelihood that the underlying cause is more systemic, and that there are root causes upstream that are driving this. It's interesting when you start looking at the state level data. This is something we've been into lately at our center, is trying to stratify the national trend by states, because obviously our national trend is a composite of the 50 states. And if you sort of look at the story for individual states, one not shown here, but I'll just share with you, is that the state of New York, which currently has the third highest life expectancy in the country, used to have a lower life expectancy than Oklahoma up until the 1990s. But then something changed. Oklahoma's life expectancy stayed pretty stable, and New York started climbing. West Virginia, which we often think of as being at the bottom of the rankings, when I was a kid, was in the middle of the rankings in terms of life. This is female life expectancy, by the way, that's being shown. So what accounts for these changes in position over time? Some of it's compositional. The populations change. Some of it is the economy. So if you take West Virginia, for example, this is a picture from a special issue of Life magazine. Anybody old enough to know what Life magazine is? So this is a 1964 issue of Life magazine about the war on poverty that the Johnson administration was launching. And this was, at the time, an old photograph of an abandoned coal mine. So by 1964, this is already being talked about as a generational change in the economy for West Virginia. So part of the changes we see in places like that, and in other parts of the country where the economy that was the main source of income for communities, whether it's agriculture or textile industries or so forth, caused big changes in socioeconomic status as well as health outcomes. So some of that's not under the control of policymakers, but some of it is. So for example, when we think about that original graph I showed you at the beginning of the US life expectancy starting to fall off from other countries in the 1980s, you start asking yourself, well, what happened in the 1980s? Can we think of anything that might be contributing to that? And there's lots of theories you could advance. And by the way, no one has the answer yet to what's actually caused that fall off. But I find it interesting to look at the income inequality patterns. US income inequality has increased dramatically since that period of time. You can see the graphs here, and there's been a fair amount of coverage about this, the ratio between managers and laborers in US companies, the gap between the top quintile and the bottom quintile. Income inequality has increased in many high-income countries, in many industrialized countries, but not to the degree as it has in the US. The US stands out in terms of the magnitude of the income inequality. So could the trend have something to do with that? And why did the income inequality develop in the first place? Again, some of it is due to macro factors that are beyond the control of individual policymakers. Globalization of markets, technology that displaced many workers and so forth, the collapse of the manufacturing sector. A lot of these things are part of the reasons for income inequality. But there is also a role that policymakers have played in intensifying the degree of income inequality. So these guys are actually in a position to control the social determinants of health and make policy decisions. And to the degree that these trends are in fact traceable to those policies, it's important to know that in terms of advocating for or against those policies when they're coming up under consideration at the federal level or in the state capital or in the local community. So for example, when you think about the 1980s and that period of time where you're wondering what happened then, here's another thing that happened then. During the Reagan administration in particular, there was a shift toward devolution. I don't know if that's a term that's familiar to you, but this notion of shifting authority and resources from the federal level to the states, giving states more control over block grants and policy decisions that they would be making that affect public health and other social protections. This is a paper by my colleague Jennifer Montez at Syracuse University where they are looking more and more at the role of how states parted company in terms of the choices they made around deregulation, devolution, and so forth, and how that might help explain that widening gap that we saw. Because if you back up real quickly, I'll go back to this map again, or to this graph again. If you look closely, you'll see that the variation in life expectancy, this is back when I was born, that there was a narrowing in the state level variance in life expectancy across time, reaching this narrowest point around here, whatever that was, 1992, can't see. But importantly, the gap is widening. It's been widening for some years now. So how long you get to live varies much more by your state than it used to. And that happens to coincide with this period when the devolution started. And so what's interesting is when you start, now I'm fast forwarding through this. This is an example, by the way, for West Virginia, the state we were just looking at, of various preemption laws. So these preemption laws, again, are taking authority away from local governments. Just with the concept of preemption is that the state takes authority away from local governments and mandates decisions at the state level that would override choices that the local governments might make in terms of public health protections. And these are examples that happen to apply to West Virginia. So for example, Kansas, a very interesting state. It's not one that you would think of as a particularly healthy state, right? I mean, it's probably not the first. Anyone here from Kansas? Okay, so I don't want to offend you. But the good news for your state, where in Kansas are you from?
Kansas City area.
Okay. The good news for your state is that when I was born, Kansas had the highest life expectancy in the country. The U.S. life expectancy, or the highest life expectancy in the U.S. when I was born was in Kansas. But here you can see their red line in terms of where they've gone. And this book here, talks about some of the social changes that happened in Kansas. This is America's Health Rankings, which ranks states every year, and you can see the trend that Kansas has taken. But what's interesting, when you start looking at the comparisons of these states over time, that same critical period that I was telling you about seems to be a point where you have this departure between the states. So when I mentioned New York and Oklahoma earlier, you might say, well, Steve, you're comparing apples and oranges. These are states with very different economies. They're different parts of the country. And it's not fair to draw too many comparisons between states that have such large regional differences and different primary economies. But when you start getting to adjacent states, it gets a little bit trickier to blame it all on compositional changes or other factors, and you begin to wonder whether, to some extent, departures like this reflect different choices that states make about how they're going to handle those resources and what policies they're going to pursue. So you see this, for example, with Colorado versus Kansas, or in the Deep South, Alabama versus Georgia, where you see they're starting out here in the 1990s pretty much in the same place. Alabama, there's its slope, and then there's Georgia. Again, you could say there may be compositional differences, the growth of Atlanta, and the large population density that the state would have in a city like Atlanta. But to some extent, it may have a lot to do with the choices the Georgia legislature may have made and other policy choices. So I'll just wrap up by saying that the big challenge in talking about this stuff in the public space with the media, with the public, with voters and so forth, is in what we call connecting the dots. Because in the public mindset, health is about health care. So if you start talking about health, they think you're talking about doctors and hospitals, and helping them understand that these decisions that states are making or that the federal government is making around these social and economic policies that affect things like income inequality, job markets, labor markets, and so forth, have huge health implications, probably far more than anything doctors and hospitals do. That just connecting the dots, helping them to think about the fact that these factors actually are related to each other, is already an important contribution to the dialogue. So I'll stop there. Hopefully we've got enough time now to have some conversation about this and delve into any particular aspect of this that you find interesting.
Excuse me, everyone. So we do have a backflow of people that are in another room, and there's only about 8 of them. So we're going to do a questioning. Before we start the questioning, we're going to start with them first, since it's probably only 1 or 2, and then come into this room.
Should I just walk in there?
No. All right. So. Yes. I'm going to make sure it works first, then we're going to go over to the other side.
Or you can do speakerphone. That's the simplest.
Oh, I feel so bad. We have room for them in here. They could just come in here.
Want to set them in here?
Why not? We got space. Okay, whatever you want.
Well, you said it's a quick hookup, right?
Yeah. Switch to here. The audio should come through the speakers.
So you're going to pipe them in?
Mm-hmm.
Oh, that's cool.
Any good? Go ahead, say something.
Hello?
She's. Nothing?
How about if we start with some questions
Yeah.
here when we set this up?
Okay, that's a good idea.
Go ahead. Yeah, if I just need people, they can just...
Okay.
Any, yes?
Comment on the argument that's articulated or made popular in the book, the American Healthcare Paradox, that makes the point that if you look at our spending on healthcare, we spend a tremendous amount, but if you factor into it the broader spending on social support, social services, that we spend way less, and that it's that gap in spending on social support, social services that accounts for the better health outcomes in many other countries like the U.S.
Yeah, it's a popular theory. The study you're referring to, it became a book, but it began with a paper by Betsy Bradley, who was at Yale at the time, looking at the ratio between social spending and healthcare spending. Initially, her first study looked at it across nationally, comparing the U.S. with other countries, and most of the countries had a far different ratio between social spending and healthcare than the United States. And the pattern that clearly showed up was that the countries like the U.S. that spent so much more on healthcare than social services were the ones with the worst health outcomes. The study was repeated domestically, and she did it at the state level and got the same finding. So states like Minnesota had much better health outcomes and were spending far less on healthcare relative to social services. The tricky problem with that kind of study is the chicken and egg question, because obviously if you're a healthier population, you don't need as much health care. So cause and effect is a little bit unclear. But still, if you take it in the context of a larger literature that's been looking at differences, and when we had our committee, we brought in political scientists to talk about this, differences in how countries approach social governance, and how much they invest in the social compact in terms of providing economic support and so forth. It does turn out that Scandinavian countries and other places like that have made more of that investment tend to have better health outcomes. And so I think there's some truth to that. It's a tricky area for research, though, so there's a good opportunity for better scholarship in the area to prove the point. and more practically for policymakers to pinpoint what specific kinds of investments seem to be most impactful, because they don't want to just throw money at anything. So knowing what kind of social services or education spending or economic support really makes the difference. So getting down to the level that some researchers have already of things like EITC, the Earned Income Tax Credit, minimum wage laws, things like that would be helpful in terms of trying to advocate for specific policies. Are we wired up with that?
Just come in.
Okay, cool. Yes.
Thank you. I came from the other room, so we can hear you.
Thank you.
The question I had kind of was how much lag we think there is between, and whether, obviously that lag differs for either different levels of government or for different types of policies, but, what's the general trend that you're seeing and kind of when they actually eventually get to health, and certainly to life expectancy?
Yeah, so it's a very complicated question. So the lagged effects issue is something that ends up having to be contended with for researchers too, in terms of how you model that and frankly what cohorts you look at. But when we've been thinking about this lately, we've realized the question really is answered differently depending on what cause of death you're referring to. So you can imagine that causes of death where there's a very short time interval between exposure to the risk and death, like the introduction of fentanyl on the streets, the lagged effects are pretty minimal, or could be pretty minimal. Whereas theories about, to take it a far extreme, theories that blame trends on adverse childhood experiences of a cohort that might have been born in the 1940s, who started to experience increases in midlife death rates during the time period we're talking about, would take you back to, exposures very long ago. And then there's intermediate effects, like if you're going to blame some of this on some of those economic changes that occurred in the 1970s and 1980s, it's likely that if that was the mechanism, it would take some time. The frustration that would cause despair is not from an acute economic shock, which actually the literature shows is often beneficial to health. It's the protracted economic distress and the sense of hopelessness that things are going to get better for your children that probably would result, would cause the kind of result people are theorizing about. So that would definitely force you to think about lagged effects there. So complicated. It depends on which cause of death we're talking about and then what theory you're testing.
Taken a look at states that have passed specific policies to see if there were any, time point changes before and after that could be explained by that policy? And then a similar question, I'm just wondering if you guys or anyone have taken a look at the longer term impacts of like a health and all policies approach. I know that's sort of more at the city level, health and all policies proclamation is sort of hard to prove the amount of, kind of shared, policy decision making and enforcement, but I'm just wondering, where the
That's great. Great questions, because there are actually two important points I want to respond to on that. So to your first question, we haven't done that yet to the degree that we'd like to. We're starting to. Right now, most of our work has been descriptive, just documenting which are the states that started deviating and when did that happen. But we've started to dip our toe in the water, and we did that around firearm-related suicides. So it's interesting that the rate of firearm-related suicides during this time period that we're talking about increased in the United States between the 1990s and the current period in all but a few states. And interestingly, the states where it in fact decreased during that same time period were states with the most aggressive gun control policies. There's similar possibilities in looking at deaths from motor vehicle mortality and crashes and so forth, where we begin to start seeing hints. And there's been a fair number of studies published over the years about what happened with the repeal of motorcycle helmet laws and other kinds of public health provisions, where you see temporally a relationship between the passage of those laws and changes in health outcomes. But I think that's an important area that we need to do more work on. We, including our center, but our field as well. But the other point you made, which I think I overlooked and want to emphasize, is you talked about local policy. One of the criticisms of the kind of state level work that we're doing is that it's ignoring what's happening at a more granular level within those states. So you take a state like Pennsylvania and look at its overall trend, and the story for those southwestern counties is a very different story than it is for here in Philadelphia or in Pittsburgh, what have you. And the same is true for New York State and most parts of our country. And so the way we think about it is that our health is shaped by place at multiple levels. So it's shaped by choices that are made in Washington, D.C. It's shaped by choices that are made in Harrisburg. It's shaped by choices that are made here in University City, right? So it's all of them. And trying to disentangle the relative impact of each of these is obviously very complicated, but we know that all of them are operating in terms of shaping health trajectories. Yes?
Can you talk a little bit about gender differences in the context of diseases of despair, considering the fact that...
Especially in regard to...
In the context of diseases of despair,
yeah.
considering that most of the time when we're hearing about the disease of despair, it's like cis male focused, and like the information that you showed was pretty striking in terms of like female mortality too.
Right.
A little bit about that.
By the way, can everybody hear the questions in the back? Okay.
In the other room, you can't hear the questions.
Okay, so the question is, can I talk a little bit about the sex-specific differences for the mortality trends? And I'm glad you brought it up, because I showed you that earlier slide with the dramatic difference for women surviving to age 50. But it's part of a larger literature that's documenting this women's health disadvantage. But in particular, in reference to your question, these trends with deaths of despair and frankly other causes of increasing midlife mortality, we do see a similar worrying pattern. So men, as you know from epidemiology, have higher absolute death rates than women. But in terms of the relative increase in these death rates in this age group, they are often larger in women than in men. So in fact, in some age groups, the increase is only happening in women and not happening in men. There are some exceptions, things like homicide in young people in their 20s tend to be more likely to be involving males. But for many of the other causes of death, including drug overdoses, it's the women that are being hit the hardest. So that, again, is an area where you have this great opportunity for interdisciplinary research for sociologists and social scientists and others who are starting to write about this now. What is it about the vulnerability of women to shifts in the labor market or economic trends or other factors that might be impacting them in a way where they have more vulnerability than men might have? Or what other explanations you might come up with for why this is impacting women more than men? Yes?
Thank you so much. I really love how simplified your graphs are and the subway work and this stuff. I think it's a really great way of communicating really complex findings in a clear way.
Thank you.
So along those lines, I'm curious if you have any advice for how to use these data to compel conservatives to support policies that would address these issues. So it seems like a lot of these policies that would address these issues are policy reforms that would stop the magnification of these issues, are policies liberals and Democrats generally support and conservatives and Republicans are generally opposed to. So I'm curious, in your work, how have you found traction with those audiences in presenting these data?
So I love your question, and the students that I had lunch with today will remember that we talked about this, that one of the big challenges for our field, and your generation, I think, can make tremendous headway with this, is not just the science of how to, calculate the p-values and do the mathematical modeling, but how to communicate this. And partly that's an issue that's not new, which is jargon and how to put things in plain English so it speaks to people. But what you're getting at, I think, is very timely right now, is beyond that, how do you frame this information in a way that doesn't shut down conversation, doesn't push people away, and yet still stay true to your values and social justice priorities and so forth. And it is difficult. We could talk for a long time about strategies that we found effective. In general, I would put it under the category of meeting them where they are. So depending on the audience you're trying to reach, the stakeholder group that you're trying to connect with, understand their worldview and what they consider their priorities, and then back public health into it. So that from their standpoint, I'm an employer and I'm worried about the cost for my employees. Or I'm a elected official and I'm worried about deficit spending. Well, that's no longer a problem anymore, I guess. But you can see if you're a conservative, you have particular policy priorities that are important to you. How does this public health argument speak to them in a way that can resonate with them? So maybe it's part of economic development. If we're going to attract new businesses to our city and build our economy, we have to address this problem. If we don't have a healthy community, how are we going to attract new talent for our companies? Things like that may resonate with them in a different way than the way we might frame it as public health people. The challenge is you got to walk a tightrope there, because you can bend so far to try to satisfy that position that you begin to abandon those core values. Like, do you talk about racism? Do you talk about systemic racism? And what kind of reaction is that going to have? So it's a very complex issue, but I think that's really an important priority for our field. Yes?
So I have somewhat of a related question, and you highlighted a bit of work in redlining, and trying to make sure that we have somewhat of a historical perspective, albeit with some groups that is impacted. They don't necessarily need to see a map to know
Right.
the implications of redlining, but I think you were spot on in terms of highlighting this historical perspective. So is that a part of this dialogue with constituents and people that may not necessarily be on this side of reform, but does that work its way into those types of conversations?
I think it's hugely important. I mean, obviously there's an extreme part of the audience that we're not going to be able to persuade. But there's many others that I think actually don't even know local history. And they operate with this narrative that has been fed to them. So they might say, well, that's always been a bad neighborhood. Or those outcomes exist because the people that live there choose to live that way, without understanding a very different narrative that said, these conditions were created. There was a history of how it came to be this way. And there is some hope, maybe I'm naive, that raising awareness among the local community and so forth about that history might have them thinking differently about how policies that were made decades ago help produce the current conditions. But that can be maybe, if policies got us where we are, policies can get us out. And we can make different choices now to reverse the consequences of economic marginalization that happened over multiple generations by concentrating investments in these marginalized communities and so forth. Again, it may be naive for some audiences, but I think there's a group out there that can be persuaded.
We have time for just one more quick question. You get the last question.
Yay. So pointing out that neuropsychiatric issues, the second after cardiac issues, as the main cause of mortality rates and suicide, drug abuse, and why isn't that correlated with how there's such a shortfall in the U.S. in regards to mental health and resources and psychiatric statistics?
Well, yeah, so my wife is a therapist, so this is a subject I hear about all the time. There's a long history of inadequate investment in behavioral health and in mental health and addiction that has existed for decades. I think this urgency around the opioid epidemic has begun to shift things a little bit, where there's a sense of panic and an appreciation that more needs to be done around mental health. But it's a very disorganized strategy that people policymakers are pursuing, where money is being thrown at particular aspects of the problem, but the core issues in terms of access to quality behavioral health services still is being neglected. And the role of upstream root causes that cause people to develop anxiety and depression and stress and so forth are not adequately addressed. So, I mean, it's maybe one positive thing about the drug crisis is that maybe more resources will go towards those needs, but hopefully it will be approached in a more rational way. Well, thank you so much.
Please join me in thanking Dr.